Oh, thanks everyone. Yeah, I've come from the UK to join you today, so I'm honoured and privileged to be able to share our journey a little bit. So I'm Paddy Rehill. I'm the CTO of Perci Health, and Perci Health we had a big problem. Our first care flow took around 9 months from design to deploy, and there were lots of reasons of why that took so long. But today we can design and deploy a care for in as little as 9 minutes. So a big part of that is of how we did that is seeing it through the lens of shipping care, not code. So today I'm going to share with you how we did it, and hopefully you can take some things away to help maybe consider what you might want to incorporate to do that yourself. So, like, I get it. It seems a bit sus, but we can really go from a blank canvas in a well studio to in the hands of a patient, a fully built out, beautiful care experience, in really as little as that. So, before I show you how, let's set the stage a little bit. So a little bit about Percy. We're the UK's largest virtual cancer clinic. We essentially want to enhance the quality of life and longevity of people impacted by cancer and their loved ones. So we would kind of want to treat cancer as a chronic condition, uh, treating kind of the side effects of the treatment of cancer, improve outcomes and reduce healthcare costs. So in the UK, we have the National Health Service. It's a public health service, and a lot of the long-term effects of cancer, of the treatment of cancer, often called late effects, often go into primary care, where they're just really not GPs or family doctors aren't really well equipped to be able to help address that kind of them kind of issues in a way that meets the needs of the patients. So it's a growing population. It's a current unmet need, and we're trying to solve for that. So before I really kind of like dig into what's this like bridging this idea to value gap, I thought it's just worth quickly aligning on what that means. So essentially moving from what we see highlighted in blue to what we see highlighted in orange. So a way to think about it is the last time you were working on improving something, the first kind of goal that you did, the steps that you took to feel like, right, you know what, I'm happy with that. That sequence is kind of what I'm talking about. So this is kind of a journey that I went through because it's really, really complex, right? So, and there's layers to this complexity. And so there's like, if we look at this kind of conceptual view, there are certain things that we are thinking of that go into the care development or care flow development process. So I've just highlighted a few here. We've got our hypotheses. So the things that ideas to have about the market or an intervention that we think will work or change an outcome. Um, and then we have best practice, the principles that we know that work. So these could be clinical, they could be design, they could be engineering, and something that's well established. And then the last things are around context and goals. So is there a particular outcome we want to deliver from this care flow? Is there certain commercial restrictions or commercial viability that we really need to explore? Um, but it's a complex flow and it has layers and complexity, right? So if we're trying to understand why is it so hard to get from here to there, well, first it's a great big circle in the middle. But what that really represents is disease complexity. Cancer is a complex condition. There are hundreds of different cancers. There are thousands of different treatments. Two people having the same primary cancer, let's say with breast cancer, having the same treatment will have different side effects. It could be because of the lifestyle, comorbidities, genetics, and so on. But it's very hard to operate in that space. And then within that, we have care complexity. So there's lots of elements to each of these layers. I'm just kind of calling out one at a time. And certainly from an engineering perspective, this is kind of how I certainly felt working with our engineering team. We had a lot of like risk averse culture. So with our nationalized health infrastructure in the UK, it is really common as a clinician to be asked to design a care flow that will never be changed. So you can imagine the anxiety. You want to get this right because you're not going to have a chance to change it unless there was something clearly, obviously dangerous or some safety issue. But there's going to be no way to fine tune it. So you can't really blame clinicians for wanting to like work in that kind of mindset. And then within that, still we have product complexity is if it's not complicated enough already, you need to figure out how do we actually get this care in a way that's drives good engagement, drives the outcomes that we're kind of looking for, right? Because again, this discipline has its own best practices, hypotheses for what works and what doesn't that's being layered in. And then right in the middle, being crushed with all the complexity top of all of that is the engineering team with care locked in code, trying to figure out actually what is it that we're trying to do in a way that's viable. And I think one of the things with this is that the further you are on the outside, the more context you have, but the least detail you have about what you're doing. And then as you get to the middle, you've got the most detail of what you're doing, but the least amount of context. I mean, can you really blame a lot of leaders or product people who are trying to build healthcare products about why it's just so hard? And this for me was kind of how I try to make sense of complexity and trying to work through it. And there's some things that we can take from complex systems because there's a lot of work done in this, right? There's complexity theory or complexity science that tells us certain things about complex systems that can maybe shed some more light on how we make sense of what's going on. So there is one fundamental, sort of inalienable, inescapable truth of complex systems, and that is cause and effect can only be realized in hindsight. What you're pumping in here and what you get out the other side is not obvious until it's been done. And so that is what we call it. It's kind of an emergent practice, right? You have to probe and then sense and then adapt. And that cycle is what you have to do to be able to get to your outcome. In my opinion, we can solve for these complexities simply by moving faster. Why? Because we learn what works and what doesn't, and we can start shifting kind of the relative size of these things here. So you'll move things from hypotheses to best practice. You know what works with your population, you know what works with your technology, and so you can start to deliver better outcomes with more certainty. So one of the key things I got away from this is we need to move a lot quicker. How do we do that? So the solution, so it's very high level, but the general gist is we can create a headless care experience. And so I've tried to kind of illustrate what that looks like, right? And this process might feel at least familiar to a lot of you, right? So if we look at this sort of darker left flow first, you've got your clinical and product teams. They're going to draw out kind of this is what we need to deliver, and then even from looking at that picture, when you obviously look at the end of it and review it, you're like, man, this is going to take a long time to get down there. And so you can see like a typical type of process you kind of have to understand how you turn that into developer requirements, how you ship that into production, and you can see how weeks quickly turn into months. And then on the right, we've got we've got an ability to build and edit care flows. We've talked about that sort of design interface quite a lot. And then within Mates, it's in the app, on the website, ready to be used. How? So what we've done is we have essentially built an app where it contains no care. What it does is it looks to AWell and looks at the pathway and sees what is the next thing we need to do, because all of the thinking around what should come in a care pathway has already been established in the design interface. And so we take things like forms that are created and maintained in AWell and then render them beautifully in the experience. And they can be changed as fast as you can, almost as fast as you can think about it, right? So you're going to the interface in AWell and you can change all the questions. And I've got a little bit more that I can show you on that on the next slide. But the gist is there's near zero engineering input required. You can change this, you can add new ones, not just forms, but all kinds of elements. So we have all kinds of content, intake flows, appointments, booking requests, and all of that kind of stuff that can be built and configured in AWell. You press deploy, and it's in the hands of a user in minutes. So let's just dive into that a little bit more. So there's some examples here. So like, this might look familiar, where there is the form engine in AWell. It looks nothing like what comes out on either side in the patient experience, but you can see that, there's also two roles here, right? Our clinical people can help word the question and understand actually what it is. There's some validated tools where the wording of it is really important. And then there's like the interface for our product team. So we've got here some JSON that just renders out how they should look like. And as an engineering team, we've gone through the process of building lots of different types of data that's pushed to the app to render it how do we look like, how we want it to look. So there's some more examples there of like forms in a little bit more detail. So this forms with slips, with sliders, and all kinds of text input and things like that. And then on the end is just some content. And I think this kind of maybe encapsulates some of the thinking around how we approach this. Because you can imagine when you are building a database of content and you're sharing that with your patients, you invariably have some kind of content management system. And that's good because it's separate from your patient experience. It allows you to have all the flows of how you write content, how you check that it's clinically safe and valid, all of the workflows for ongoing monitoring, all of that happens outside of where it's being read. And that's the kind of approach that we're taking here. So in our care flow in Airwell, we have we can include a library of content and change it to whatever we like. And when it's published, it looks amazing in the app. So what next? So there there is currently around 1.2 million people in the UK that have cancer or living with cancer as a chronic condition. That's expected to go up to 5 million by 2030 and 100 million globally. So it's a growing population. We need to be able to move quickly, establish these care flows, and establish our ways of operation so that we can get this support to meet this unmet need in a greater population. We're also kind of using the phase of the business that we are in now to understand or to prove how we can give a return on investment on how much does it cost to improve the outcomes for patients so that we can remove that cost from primary care. Um, and so my kind of call to action would be this. This is by no means the sort of complete answer, but it's significant enough for even the largest organizations to consider that the speed of iteration is really, really important. And you can remove care from your code, free up your engineering team, and deliver care flows much faster. That's it for me. Thank you very much.